Good morning or good afternoon to those who join us from the East Coast, and thank you for joining us. My name is Sean Forster. I'll be your moderator for today's discussion. I'd like to be the first to welcome you to our annual webinar, the Call Letter Chat, Understanding and Planning for CMS's Policy Changes. We've got a lot of exciting content to get to, so let's go ahead and get started. I do have a few housekeeping items to start us off. During the presentation, all participants will be in a listen-only mode, so there's no need to mute your lines. And although lines are muted, we do encourage you to ask questions during our time together. To do so, simply use the questions window located on the right side of your screen, type your question into the box, click send, and it will be sent directly to me to ask our speakers. And this presentation is going to be a little bit different from our usual format because in addition to the Q&A session we'll host at the end of the hour, I'll be pausing at certain points before then to ask our speakers any questions we've received about a topic they just presented on. So be sure to submit your questions as you think of them so I can ask them to our presenters. I should also add that should you encounter any technical difficulties during the webinar, please also utilize the questions window to describe your issue, and one of our support staff will follow up with you to troubleshoot. Our webinar will also feature polling questions today. When we get to a polling question, I'll pause our speaker to read out the question, and you'll have a minute or so to record your response. We'll then share the response, and in case you're worried about any sharing of information, no attendees will be able to see your individual response. It's just the sum totals that are shown, and we like doing this because it's not that often that we get so many people involved in risk adjustment together in one place. So it's kind of interesting to see what are some of the challenges or opinions that your colleagues have as we face some of these similar challenges. And with that, I'm happy to introduce our speakers for today. Tom Peterson and Pam Klugman both bring with them more than 25 years of experience in healthcare. Together, they founded Clear Vision Information Systems, a provider of software and services to optimize care and revenue for plans and providers across the country, a company that was acquired by SCIO in 2016. Before then, Pam and Tom both served in leadership and oversight roles for Blue Shield of California, Blue Cross of California, and Cedars-Sinai Medical Center. With expertise in system development, data analytics, and risk adjustment strategies, Pam is a recognized industry expert. Until recently, she was active in the Industry Collaborative Effort, or ICE, since its inception, and co-chaired ICE's Risk Adjustment Data Acquisition and Reporting, or RADAR team for several years. Last year, Pam moved from day-to-day operations to her current role as a risk adjustment consultant for SCIO. In this role, she continues to track industry announcements and regulations to ensure that those trends are also reflected in the solutions we provide. For his part, Tom's extensive background in clinical data related to risk adjustment, system design and analysis, provider outreach, and training program development led to his involvement in ICE, the development of training forums, and best practice presentations on risk adjustment for the industry. In his role as SCIO, Tom leads the operations in our Westlake Village, California office, overseeing the strategic direction and innovation to ensure alignment with evolving industry needs. We've organized our presentation today into 4 sections. The bulk of our time will be spent on changes to the CMS-HCC risk adjustment model, as there are some key changes we feel are not getting enough attention in our industry. We'll briefly touch on some of the important changes to CMS reports and STARS ratings, and we'll conclude our presentation with a sampling of other topics, some from the call letter, some not. As I mentioned, we'll have a few opportunities to field questions throughout the presentation, but with any remaining time, we'll reserve that for an open Q&A at the end of our hour. And with that, I will step aside and hand it over to our presenters. Pam?
Thank you, Sean. And hello, everyone. Again, good morning, good afternoon. What we're going to start with here is some information directly from the call letter. The table is showing the year-over-year change from the advance notice to the final announcement. The bottom line is better than expected. And also of note, CMS typically reflects the % of increase as a result of coding improvements. However, they haven't included it in the table this year, but it is estimated by CMS to be 3.1%. Taking that together with what's in the table, you could translate this to an upwards of 6% increase in revenue. So what is also better than expected is that CMS is forecasting a negative 0.04% reduction in as a result of the EDPS transition. So we're going to get into that in detail a little further in, but it's really only a 0 or a 0.04 reduction. Seems rather minimal. And again, there's some interesting caveats about why that might be so low this year. So let's go into the changes to the risk model for payment year 19. And payment year 19 is a blend. It is a blend of two models. The model we are all used to, which is referred to as the 2017 model or version 22. On the top, this is pretty self-explanatory. They've increased the normalization factor. The coding intensity factor is 5.9%. And for payment year 19, using the 2017 model, the data source will be RAPS and fee-for-service data. So for payment year 28, for this current payment year, we're using model 22, but it's using RAPS, fee-for-service, and EDPS and fee-for-service. So there's going to be a key theme throughout the presentation, and that has to do with the data source and the payment model. So the first time I read the call letter, it wasn't immediately apparent that this would be like the first initial transition away from RAPS to EDPS as the sole data source. And again, as we move through this, you're going to see more detail and specifics about what I'm referring to. So for 2019, it's going to be using the 2017 model or version 22, and then it is also going to blend with that the new model, which is referred to as the 2019 model or version 23. So we have, again, different normalization and coding factor. Coding intensity is the same because it's the coding in the same year. The key thing is that the model, so the V23 model, will only use EDPS and fee-for-service from all sites of service and inpatient RAPS only. So that's key, inpatient RAPS only. CMS in the advance notice was trying to decide between two multiple condition models. While they did pick one, they are not going to implement it in 2019. On the right of the slide, you can see some new disease conditions, 3 categories: substance abuse, mental health, and chronic kidney disease. Now, there is a massive spotlight on opiate abuse, and that has become a focus for a lot of health plans. And in HCC under mental health, HCC 59, the doctor must use the word major in the documentation for it to be coded and rolled into HCC 59. That's not new, but I just wanted to point that out. A lot of times people will put depression and it gets incorrectly coded as major depression. Unless the physician states major, it cannot be coded as major depression. The model version 22 has been recalibrated using they were using updated data to calibrate. They're going to use claims 2012 through 2016, updated with the 2018 indices for wages and geographic practice costs. So this is information directly from the call letter. We need to distinguish between blending of models, which is V22 and V23, and data source based on model. In the past, we've used EDPS and RAPS as the basis for blending, but so that's not new to us. What is new is the blending of models also incorporates different data sources. Let's dive a little into the detail about how they're going to blend next year, keeping in mind that the activities or dates of service starting July 1, 2018 are the first dates of service that will be impacted by this, because the July 18, 17, 18, it would be the July, it'd be 7/1/17 through 6/30/18 which will drive the January 19 payment. So, you know, we're already in a blending mode, almost to the end of the blending mode for January. So this is very, very important to note. The first item to review is in blue. 75% of the score will use the 2017 model, or V22, from RAPS and fee-for-service. Notice there's no mention of EDPS to be used in that model. Now, let's go over to what's highlighted in yellow or gold. The 19 model, also known as version 23, is going to be 25% of the score. It will use EDPS and fee-for-service from all sites of service and RAPS inpatient records. So no physician or outpatient or ER will be coming from RAPS for the 2019 model. This is the biggest transition to date towards EDPS as the sole data source. The inclusion of inpatient data from RAPS, I believe, is the contributing factor to the negative 0.04, i.e. being such a low number for a transition to EDPS, because, again, the RAPS inpatient can be utilized for that model. So the blend is not only by site of service, it is blended by data source. Something unique that many people aren't integrating into their thoughts, at least in the several discussions I have. Our next slides are going to go over this topic because it can be confusing, and we're even going to even took us a few readings of the call letter to get it a way to concisely reflect this in the tables. The key concept to understand is the data sources are tied to the model. So for model year 2017 or version 22, it's RAPS and fee-for-service. For model 2019, it's or version 23, it's EDPS and fee-for-service plus inpatient RAPS. So let's really quick, because this is a little overview here on the data flow differences between RAPS and EDPS. It's a 3,000-foot view. The MAO 2s and 4s are not the only files that we get, of course, on the EDPS side. We're just trying to illustrate that there's an added complexity and time lag between what we've traditionally used for years with RAPS and the go-forward EDPS. In the current environment, we push data through both doors. This time, if it doesn't make it, if the data, the information doesn't make it through the EDPS door and it's physician data, you're going to be at a loss for revenue. The selection criteria for RAPS is basically plan-driven, and the selection criteria for EDPS is CMS-driven. So to the extent that the plan logic matches the CMS logic, you should be fine. But the degree of variance may show up in your revenue. So this table shows you, this is going to show you the proposed blend over the next 4 years, and it's solely focusing on the model blend. An important caveat is that anything beyond 2019 is proposed. We only really know payment year 2019 for certain. For example, 2018 was originally scheduled to be based 50-50. So the top line for 2018, the aqua, I suppose it is, the 15% is EDPS and fee-for-service, and the 85% in blue is RAPS and fee-for-service. The 15% EDPS and fee-for-service is going away. In other words, we're not going to be using EDPS for anything related to version 17, version 22, payment year model 17. The payment year 19, the blend of 25 and 75 is a model blend. Payment year 18, that was a data source blend. 2019 and subsequent are model blends. And of course, the yellow or gold is the version 23 using EDPS, fee-for-service, and RAPS inpatient, and the 75% is RAPS and fee-for-service, and so on down the rest of the line. Now, PACE and ESRD data sources, the ESRD model is going to be recalibrated using the same data sources, i.e. EDPS and RAPS. They're going to use 2014 diagnosis to predict 2015 expenditures, and the last update to that calibration was in 2012, and PACE will still have the 2009 denominator.
Great, thank you, Pam. That brings us to our first polling question of the day. So if you go ahead and please launch the poll. And this gets to kind of a comment, Pam, you just mentioned that, we know that CMS has proposed this timeline to 100% EDPS data. They've done so in the past. So our question is, will CMS stick with this timeline of 100% EDPS / version 23 by payment year 2022? So a little bit of a, of a guess or an estimate or an educated guess, I should say. But curious, because again, this is one of the few opportunities we have to collect, responses from more than 100 people that we have on the call here today. And seeing the live results come in, it's really pretty interesting. So we'll give just a few moments for people to respond. If we go ahead and close the poll and share the results, it was hovering at about 49-51 for most of it. We must have just gotten a response. It's a dead tie at 50-50.
Wow.
Yeah, for the 125 odd people that we have on the call. Yeah, about split evenly. So we'll move ahead. So now back to Pam. We've talked about the model blend. I think our next slide here is going to talk about the side of service changes done for that. So I'll hand things back over to you to walk us through this next table.
Okay, thank you, Sean. So here we're taking a look at data source and distinguishing between data source and site of service. Currently, payment year 2018 is using exclusively version 22. 85% is coming from RAPS and fee-for-service, and the site of service is irrelevant, physician, outpatient, inpatient. The 15% is coming from EDPS and fee-for-service, and again, physician, outpatient, inpatient. Version 23 is not in play. So, as we move into next year, and again, we have to remember this started 7/1/17 through 6/30/18 is going to feed January of 2019. So, it will be catch-up for a while, and I don't mean the kinds of variety. So if you look at payment year 2019, 75% of the data is going to come from RAPS and fee-for-service, all sites of service. When you get down to version 23, you'll notice the physician and outpatient from RAPS and fee-for-service are not there. There is one field that's in both, and that is inpatient. So you're going to have your inpatient from RAPS and fee-for-service. You're also going to have your inpatient from EDPS and fee-for-service. So, and then the outpatient and physician. So what's happening is, if you don't have your outpatient, how do I say this? If you don't have your outpatient and physician data in your EDPS side, you're going to lose 25% of that payment for version 23. So again, 75% from version 22, 25% from version 23, and that's going to increase as time goes on, which means we're going to be moving away from the RAPS and fee-for-service to EDPS and fee-for-service, and we can only hope that they continue to take inpatient from RAPS as we move forward. And CMS has given us information we'll look at in a moment on the next slide about why they did this for this transition. So however you're going to do this, whether you do it in-house, whether you outsource it, whether you contract with someone, you have to make sure that your inpatient data is as robust as possible so that you get 100% of your inpatient data in and get payment on that. You also have to make sure that whatever you would have put on a RAPS file, or whatever you did put on a RAPS file for physician and outpatient, is reconciled to what's on the EDPS side for physician and outpatient, because 25% of that will be from EDPS and that will be growing. So the question is, why is CMS supplementing the EDPS data with inpatient? Well, here's exactly from the call letter. And they said amending the inpatient from encounter data with inpatient from RAPS will improve the completeness of the data. So they envision that the inclusion of this RAPS data in encounter risk score is temporary. And in addition to improving the completeness, it'll minimize any impact from incomplete for the remaining plans that face operational challenges in submitting encounter data. This goes directly to why they feel the impact for this year, or for 2019, will only be a negative 0.04%. So again, in the past you had all sites of service, all data sources. Now inpatient data is critical, as it always has been. So let me just again state, whether you do it yourself, whether you engage a third party, it's worth the effort to get all those inpatients. And it is much easier to get multiple inpatient diagnoses on in a RAPS file than it is in a EDPS. You should pursue it, and you should reconcile it. And that goes for all sites of service and all data sources.
Thanks, Pam. That actually brings us to our second and third polling questions, which we'll be asking back to back. So go ahead and get our second polling question launched. And this goes to the idea that we really are in the middle of this blend today. If the dates of service from July to ending in June that are going to inform the initial payment in 2019, our question is, how do you assess your organization's readiness, if you happen to know, for this transition? Are you fully prepared and ready? Is it an ongoing project? Have you had some meetings, hopefully, to discuss the transition? Or maybe, this is something that's newer to you as an organization that you'll want to get up to speed with pretty quickly. So we'll give you just a few moments to respond. Looks like about 51% of folks, 53, have responded to our poll. Let's go ahead and close and share the results. And looks like for most, 51%, it's an ongoing project. So good to see that the majority of people have started working towards make sure that they are covered for this transition. The remaining 50% are split pretty evenly between the rest of the responses. 11% fully prepared and ready, and the remainder either have had some meetings and a few haven't thought about it just yet. So I'm going to go to our next poll question, because the other thing that, Pam, you had mentioned is the importance around reconciling your data. So we want to ask, is that something your organization currently reconciles RAPS and EDPS submissions, to see if there's any discrepancy between the two? So you may not know, and that's okay. We have a not sure option here, but between yes or no, is that a project that is currently undertaken at your organization? Go ahead and let's close the poll and share the results. It looks like here again about 45% do reconcile, so we're glad to see that, and the rest either are not sure or are a no. So thank you all for participating. We're actually going to now pause for our first Q&A mini session. So I'll get us going with our first question that I'll pose to Tom here, and then I'll also encourage folks who've had about 5 or 6 questions come in throughout the presentation so far, so we'll ask those, but leverage the question module on the right side of your screen to submit some as we go from here. If we don't get to your question during this session, we do have that end Q&A session as well. But I want to ask you, Tom, around this idea of reconciliation. This is something that I know that we've encouraged in the past. How has this changed at all, given this model blend, to either increase or decrease the importance of reconciliation?
it's my personal opinion that the reconciliation process is going to become even more important because currently, your payment is adjusted, this year, for example, by 15% if you don't get it in EDPS and you're only sending data on RAPS. So RAPS is a file format that we in risk adjustment have used since its inception. So we're very good at creating RAPS data. It's a very simple format. Anybody can read it. The complexity comes in the way of ensuring that you're also submitting that very same data service in the EDPS world. And there's a couple of nuances that Pam sort of touched on earlier. And the nuances are, for filtering for RAPS, it is plan driven. So each plan was left to their own devices as to what constitutes a qualified diagnosis code for the purpose of risk adjustment. And for EDPS, CMS has said to the industry, you send me everything and I will do my filtering. And they've also finally released what their logic filtering is. So knowing that there could be a delta between your RAPS submission and your EDPS submission, now is the time to sort of get that house in order so that you can understand what the criteria is and do your best to mimic what CMS is going to see for your membership. Because even though, this year we're still submitting all sites of service under RAPS, when it comes to version 23 and they're only looking at inpatient data, we just need to make sure that all the data that gets submitted for EDPS, in addition to hospital inpatient, so this is hospital outpatient and physician sites of service, are submitted. Now is the time just to do some validation, check to make sure that your processes are correct, that any changes in logic that you may need to make, now is the time to uncover all of those items.
Great, thanks. I have a question here, and I'll pose it to you, Tom, but Pam, feel free to add to it. We've mentioned RAPS plus fee-for-service, EDPS plus fee-for-service. Can we explain what we mean by the fee-for-service piece?
Yeah, so fee-for-service has always played a part in risk adjustment. It's so funny. I noticed the same thing when this notice came out, that they're mentioning fee-for-service a lot, and really nothing has changed from in the past. If we have a member who joins a MA plan from fee-for-service, those diagnosis codes, those HCCs, stay with the member. So that's what CMS is referring to in this fee-for-service world. So they recognize the fact that as a member's joining your plan, that fee-for-service data should count towards risk adjustment. You'll never have RAPS data for these dates of service because they were not your member. And so that's why they're mentioning fee-for-service so often. And they're giving the industry credit for that, which is the right thing to do.
Right. Since it's a predictive model, last year's diagnosis drives this year's payment. And as Tom said, if they weren't yours last year and they came from fee-for-service, then that data has to be utilized to calculate their risk score while they're with managed care.
And this is probably related to another question we received here, and that's, will version 23 apply to members with dates of service July 2017 to December 2017 for prospective payment in 2019?
Yes.
Okay. And I think the
right?
situation here is, and to continue, or will version 22 apply to those dates and version 23 would apply for 2018?
The dates of service utilized for calculation of risk adjustment are based on whatever dates of service are feeding the payment year. So for 2018 payment year, it's 2017 dates of service, but for the initial payment in January of 18, it was 16 through 17. So for 19, which will be using version 22 and 23, it'll be 7117 through 63018 that will drive 17. Does that answer that question, you believe?
I think so. And I think the connection to the earlier question is that if they weren't your member and you don't have dates of service, fee-for-service
Correct.
would then cover
Correct.
for that member.
Correct.
Okay.
Yes.
And we also have a question, will the slide deck be made available? It's been very helpful. Thank you, John. And yes, we will make the slide deck and the recording available. Let's see.
Well, one thing I just wanted to add, you have to keep in mind that EDPS is a very different animal than RAPS. And the way fee-for-service claims, they more closely resemble EDPS. A physician sends in a claim, and even a hospital sends in a claim to adjust payment, or they forgot a CPT code. And oftentimes on the physician side, the CPT code is what drives the payment. And we'll get to this a little later. But the CPT is driving the payment, so they may want to get a different or more CPTs in, and they don't really necessarily care about the diagnoses, and they overlay. So they overlay a diagnosis, maybe you had 5 diagnoses, and then they want to send a different CPT, and they only send 3. Now you have 3. So where RAPS, it's much easier to add diagnoses. No matter the site of service, it's much more difficult, and it's hard to predict what the fee-for-service risk scores will be, i.e. risk scores based on fee-for-service, just because of the claims processing differences.
And before we move on, I do want to ask, it seems to me that there being an overlap with the inpatient RAPS data for payment year 2019 used in both version 22 and version 23. It seems that it could potentially be an opportunity for health plans and providers to get additional data in. Maybe, Tom, you could ask or talk a bit about what plans and providers can do with this way to maybe better supplement their data that if it was without that overlap, they may not be able to do.
Good question, Sean. So the drive for inpatient data, and I think that is one of the reasons why CMS is actually allowing the industry to continue to send inpatient diagnosis codes on RAPS data, is I think driven in most part by the fact that over time we as an industry we have learned how to get more diagnosis codes, where to look, what stones to uncover. We as ourselves many years ago we discovered a way to get into hospital systems to secure this data for clients, and over time people kept telling us, you guys, this is eventually not going to be needed anymore when we get to EDPS. And so here we are, we're at EDPS world, and CMS recognizes that garnering these extra diagnosis codes still count, and they count so much so that when CMS compared the NA world with RAPS data to the fee-for-service world with diagnosis code data, they've noticed that there's a definite distinction between the volume of data driving risk adjustment from RAPS is much greater than hospital inpatient data. So, I can personally tell you that I have seen up to 60 diagnosis codes on a single inpatient stay. Well, yes, that's not the norm. The point is that there's much more data to be mined, and there are some very easy ways to get that data. And like I said, it's something that we at SCIO have done for years. We continue to do it, and it has just grown over time. And having this uncovered in the notice has just validated, that the service that we do is actually still very valuable, at least for the next few years until CMS comes up with some other change. So it's a well worthwhile endeavor.
Great, thanks, Tom. In the interest of time, I'm gonna let's continue our deck, and then the few questions that I have here, we'll ask with the remaining time at the end. So I think going along with that, Tom, you have a couple slides here around what that impact of missing those kinds of codes could be to a plan. So if you don't have that documentation, what that impact could be to a plan and provider. So
in this example here, so many of us have seen, if you've been in risk adjustment for any amount of time, you've seen slides similar to this. We took that and we tweaked it slightly for the purpose of today's discussion. So, the first example is you coded nothing. It generates $7,000 a year. In the second example, you've got some data submitted via EDPS. So your diabetes without complication got a risk score of 0.181, vascular disease without complication 0.324. So the payment now went from $7,000 to $12,500. But after looking at the chart, a certified coder has been able to actually identify data that was missed, and you got it through on RAPS. So now instead of a 0.181 for diabetes, you've got 608, because now this time you've actually coded the complication. And the vascular disease with complications versus without. The CHF has been picked up, and now because of the CHF, you now have a disease interaction. So the payment now jumped to $27,000 a year versus the $7,000. And I can personally tell you, just this morning, I met with a coder, and we were going through data in an electronic medical record, and we had an encounter that had a single diagnosis code. And when we were done, we found 4 more that were risk adjustable. So as an industry, we need to sort of bring this, shine a big spotlight and bring this to the forefront to make sure that everything is being picked up. Because remember, services are being performed, somebody's bearing a cost for this care, but we want to make sure you get reimbursed appropriately. So here on this slide here, we talk about knowing your membership and your providers inside and out. And so it's really a matter of creating some transparency here. You know, that's sort of the foundation of which, you know, the evolution of our company is based on this, creating transparency that never existed before. So being able to identify and quantify missing data and do it in a way that you can actually share this information in advance with their physicians so that you can make sure this information, the members get called in, have these conditions assessed, documented. Documented is the key word here, and so they can be picked up and coded. Looking at benchmarks, you want to make sure that, you know, is everybody in line with their peers? Sometimes just identifying items at this level, looking at the PCP RAF scores, you can identify breaks in data, and addressing those breaks and getting those things fixed can oftentimes close a bunch of gaps and trigger more HCCs. So that's a really important thing to focus on. The next one is reconciling RAPS and EDPS. I've already talked about this, but it is really, really important for the industry to understand why is there a delta, and there's going to be, because when people create a RAPS file, we were all left to our own devices. So as Pam mentioned, to the extent that they're in line with each other, you're fine. To the extent that they're different, it's going to have a revenue impact. So, and the last thing just to touch on quickly is the need for including prescription information as your suspect identifier. You know, we here at SCIO, we've done this, we've gone through a couple iterations of this, and as we get better and better at perfecting the logic, this is a tremendous place to identify missing information.
You know, one other thing that I'd like to note on this slide is, because we send, or supposed to send everything to CMS on EDPS, I don't know if everyone sends everything on RAPS, or if they, that it's just risk adjustable diagnosis, or they send all. But CMS has all this data. They know their changes. They can go back and look historically back to 17, especially on the EDPS side, and see, okay, what's risk adjustable with this new model that we didn't necessarily capture before because it wasn't risk adjustable in the 2017 model. So my question to everyone on the line is, do you have the ability to do that? And are you able to see that? Because you could find a gap in that, something that is now risk adjustable that wasn't before, if you, whatever solution you use can go back and historically show you that.
Great. Let's move on to kind of the second portion, and that's our updates to CMS.
Okay, so the evolution of the MAO-004. For those of us that have been around for a while, we know that it's had several iterations. The most recently, looking at this complete timeline, the most recent was phase 3, and the changes are being made to positions 17 through 28. And what they're doing is they're changing the HICN, or the railroad beneficiary number, to an MBI, which is a member beneficiary identifier. So let's go over to the next slide here. So here's a summary of the impact of the member beneficiary identifier implementation on RAPs. So there's some, this information actually came from the CMS January user group, the EDPS and RAPS user group, and you can go on to CSSC operations and get those slides. But in case things aren't complicated enough, before the MBI transition, which means before 1/1/2020, if you put the MBI on the RAPs, it will be rejected. Okay? So any ad submissions or any submissions on RAPs, you need to continue to use the HIC number or the RRB. When you do a delete, it has to be the same identifier that you use to send in the initial, which on RAPs must be the HIC or the RRB. During extended transition, the 004 reports will include the member identifier which was submitted, i.e. that's the change in the columns, I think I said 17 through 28. So the ad submissions during the extended transition can be HIC or RRB or MBI. So RAPs can be either after implementation, but until that time, RAPs has to be the HIC number, while the EDPS can be either. And again, this information, the only place I was able to glean this information was from the January CMS user group. So my question is, why isn't it more broadly known? It's like, I mean, they don't let although physician groups don't send in RAPs, that's true. So we're all going to have to create cross-reference files from the MBIs, the RRBs to the the HICNs and the RRBs to the MBIs, because it's not complicated enough today. So I just wanted to bring that up. So let's take a look now at the model output report. So there's a new field that will be on the model output report, and it's going to be record type H for version 22, and version 23, the EDPS and fee-for-service, which is the 25%, and then the D is the RAPS and fee-for-service, which is the 75%. Okay, so, and the first time we're going to see this will be on the interim finals, and the reason it's on the interim finals is that the EDPS submissions were pushed back, so there's going to be interim final, and then there's going to be a final. I think everyone's aware that during the year, everyone's paid at 100% based on RAPs, and then all the adjustments for EDPS come up during the mid-years and the finals. The changes to the MOR are to help facilitate understanding the data source for the calculations. So again, the first time you're going to see this will be the interim final for 17, which should be mid-year 2018. So it should be like August, September of this year. Clear as mud, I know. So we're briefly going to go over some of these, some star rating changes. There's some added measures having to do with statin. I'm not going to necessarily read all this because you guys can read it. There's the BAPP has been removed, and there's new display measures. Compared to past years, there's not much in the way of changes. What is important to note is while 4+ stars will continue to receive a bonus, anyone below that will not receive a bonus. And plans impacted by 2017 disasters are going to receive some special considerations. Additional and future changes, some additional and future changes. You can look these up later, so we don't need to go over them one by one. RAND is developing a technical expert panel of reps across stakeholder groups to obtain feedback on the star rating framework, the topic areas, and the methodology. While there's not a lot of STARS updates, there are ways to use quality measures to proactively outreach to engage members. And I think, Tom, you're going to go into a little more detail on that?
Yeah, so typically today, we as an industry, we're mining for risk adjustment information, HCCs. We want to make sure members get assessed for their conditions so that we can ensure that our payments are in line with the care that's being provided. And where I think a shift can happen, that I think as an industry, as we move towards different data sources for payment, we can also be looking at a new way of identifying or prioritizing our work. And what I mean is that identifying members who maybe qualify for a particular STAR measure or a HEDIS measure, and there's a gap in that care. So, outreaching to a member to say, Mrs. Jones, you need to come in to have a mammogram is probably much better received than, Mrs. Jones, we need to get you in to assess your COPD. So at the time that the member comes in, of course, you're going to assess the COPD, but the outreach to the member really makes the member feel like somebody is looking out for them. So we want to come up with ways where we can engage members. We understand that some members are reluctant to go into the doctor, but coming from a point of, I want to make sure that, you get all the screenings you need, or you're performing the tests that are necessary to ensure that the quality of care is where it's supposed to be. You can also assess ACCs at the same time. So it's just a little bit of a mind shift. And in the little pictorial that we have here, you can create specific messages for members, because this is a really great way to reach out to members, communicate with them, and then look at the list at the end. You start with your HEDIS measures first, it overlaps into STARS, and of course in ACCs is what we wrap it up with. So just a little different perspective on how we may want to look at doing our focus for risk adjustment.
And just as an aside, Tom and I have both come from both the plan and provider side. And when it was our task, actually it was Tom's task, to pursue closing, I think they're called administrative measures for HEDIS. In doing that, of course the HEDIS scores went up, but the risk scores went up. And then when we were pursuing data for risk adjustment, the HEDIS scores went up. And we had auditors on both sides of the house saying, how'd you do that? How'd you do that? And this was when risk was in its infancy. And so I think it just goes to show you that all data, as robust as possible, can help your quality programs and your reimbursement programs. So, combining them and only having the member have to come in one time is better all around for everyone, and it's a more efficient use of resources. So we're going to take a quick look at some of the other industry trends and forecasts. We mentioned earlier the payment condition count model. So this is some graphs, and in the advance notice, CMS proposed two different ways to look at other conditions the member had. There was a payment condition count, which only uses conditions that are within the CMS-HCC model, and the all condition count, which expands the definition. It's for all conditions, so they could be in or outside the model. But that skewed the impact, and it's very much way more erratic. So if you look on the right, the all condition count, the payments were all over the place, but the payment condition count model, the variance was more toward the positive and not as far off the line or off the status quo. CMS is going to use the payment condition count model, believing that it will improve the accuracy of the risk adjustment model. It's the conditions used in the payment model tend to be more clinically severe, and the majority classified as chronic. In contrast, if they use the all-condition approach, they would count many conditions that don't meet the criteria of being clinically meaningful and cost predictive, and would include more acute and items that are traditionally being treated as a single therapy course. CMS feels the payment condition model is more industry friendly than the status quo, and a better cost predictor than the all condition count model. So we sort of look at this as a more global disease interaction measurement. So you're going to count how many conditions within the model you have and make payment adjustments accordingly. Expansion of supplemental. This slide is more directed to the health plans on the call. It doesn't really relate to providers unless you happen to be a provider that sits in on the benefit design with your plan. And it is, I think it's beneficial to understand that CMS is looking for ways to make the MAs more attractive. So they're letting you have more leeway and benefit to the design to include more supplemental information, or excuse me, supplemental coverage. So a little more information sort of outside the call letter, but CMS has been doing this for a number of years. These are the dates of service and payment years that CMS will be running for recoupment in 2018. While it doesn't remove the obligation to return overpayments within 60 days when you find them, this is showing you the payment years and the dates of service that they will be running overpayment recovery. So this is only for deletes. You can't go back and add things, but it's interesting. We've seen a big spike in deletes because we have all realized in the industry that it's better to self-police than to get an audit finding and have that error rate extrapolated over your entire payment. So we do see a lot of our clients doing many, many more deletes for prior years than we had, say 5 years ago. So I mentioned recalibration a little earlier in the presentation. So in case anyone feels CMS is not moving in the direction of repricing based on the MAO data, you would be forgiven if you missed it because it's not something CMS is actually trumpeting. In our review of the CMS responses to comments to the 18 advance notice, within the coding intensity questions, we found some illuminating information foreshadowing CMS's future move in this direction. So this should give everybody much cause for concern. While the primary topic and question being answered is relative to coding intensity, the more significant item to notice is the statement about using MAN counter data to reprice the model. Now, if you go to if we move forward here, we are looking at the basics of calibration. And this is a slide that we have used in the past, and it's extremely oversimplified, but it's showing how the cost could vary between fee-for-service and MAO for the same condition, purely based on the CPT submitted. Since costs as calculated by CMS are always based on fee-for-service pricing methodology, in other words, on CPT codes. So repricing based on the MAO EDPS submissions could potentially be far lower than anything we've experienced with fee-for-service-based pricing. In the example, we see a large disparity in cost between fee-for-service submitted CPTs and the MAO submitted CPTs, both for the same diagnostic conditions. As you can see, disease cost using fee-for-service is $1,173, while for the MAO, for the same condition, is $456. So it's true that our risk score as a raw number could be higher than it is today, but if the underlying cost basis is lower, then the corresponding reimbursement will be lower. So a risk score of 0.980 with a base rate of 1,000 is much higher PMPM than a score of 1.5 with a base score of 400. So it equates to a difference between 980 PMPM versus 600 for the same condition, all based on the CPT codes driving the cost. And the fact that traditional Medicare has been doing this for a long time. So CPT is the cost calibrator, and in fee-for-service, payment is based on activities versus health conditions. So maybe you're sitting here looking at this going, well, why does that matter? Well, because the deficiencies in the submission of CPTs impact the perceived cost of treatment based on CMS's method of calculation. again, fee-for-service has been doing these CPT submissions since the 60s, so they've had in excess of 60 years, let's see, 60s, that would be 40, in excess of 50 years to perfect coding and submission of activities. We've had far less, and our emphasis has always been documentation for conditions. So it's important that we keep this at the forefront when we're working with encounter data submissions. And even in all of our discussions, we talk about getting all the diagnosis in, but tied to that, we must make sure that we get in all the CPTs that we, as if it was a fee-for-service claim, to make sure that when it's calibrated based on our, and I say this with air quotes, our CPT codes, that it is, as robust and reflective of the cost as possible.
Thank you, Pam. And we were to have a polling question here, but I'm actually going to suggest that we skip it in the interest of time so we can get to some of the questions we've been receiving in here. So I'm going to put it to Tom to kind of wrap it up, and then we'll enter our final Q&A for the day.
Okay, so in today's sessions, these are some of the items that we've talked about. So we've covered the major components of the HCC risk adjustment model that's coming upon us, the recalibration of version 22 and this new version, version 23, utilizing EDPS and inpatient RAPs. And so, you know, more to come. As more information comes out, we'll continue to share more information. We've covered the CMS reports, the MA004 evolution, as you could see on that slide with the blue arrow. There has been lots and lots of changes and morphs and corrections and whatnot to this report. And so we're hoping that it finally gets stabilized, as well as the changes to the model output report. So for a lot of people who are trying to do this on their own, we thought it was more complex a year ago when they were coming up with all these new models, inpatient, or community, institutionalized. Now you're community disabled, and so this added a new layer of complexity to getting your arms around risk adjustment and what steps you need to take with this new model output report. We've covered the star ratings and some of the changes that are coming towards for 2019, and we anticipate even more updates off in the future. And then we've covered future trends. So this payment condition count model is actually very interesting that CMS is looking at that for the industry. I think that this is showing, CMS is showing us that they do consider all the work that we've done and the cost to bear that. And supplemental benefits we talked about, risk score reruns, and the model recalibration. This is what Pam just talked about. It's really important that we understand what that really means is when they begin looking at our own data.
And we actually got a couple questions around that that payment condition count module. So I just want to confirm, it will not be used this year. It is, they've selected it, but it'll be starting in payment year 2020. Correct?
Correct. Yes. Well, we'll find out for sure when we get the advance notice, but yes, theoretically, it will start in 2020. It will not.
That's always a good qualifier to have with these things. Besides that and the disease interaction factor, are there any other risk adjustment added for members with more than 3 chronic conditions? So I kind of think it would be the multiple condition. So yeah, I think CMS has heard that as a concern, and this is their solution to it. So we're happy that there's a solution, but for this payment year, unfortunately not. Right,
for this payment year and 19, it does look to us that it's an expanded disease interaction concept.
Yeah. Another question on that is, when they're talking about condition, that refers to the ICD-10 codes that are being used for it?
The condition,
The
HCCs. The HCCs is the condition. Well, ICDs roll up to HCCs, and HCCs have a weight.
There we go. Okay. We have a question here, and this is another confirmation that RAPS and EDPS split in version 22 is still the rule of the land for payment year 2018, and the split is happening for 2019 and beyond. Just
the split in model and data source is happening for 2019 payment year and beyond.
Okay. So, and we got a lot of questions here around recording and slides available. We will have the slides available and the recording. So I think those tables that Pam had mentioned or had spoke to in the beginning do a nice job of illustrating how that is broken down for payment year 2018 versus 2019, and then anticipated beyond that as well. So we will make those slides available. Of course, if you have any other questions or one clarification, we're here for you to have to answer those questions. So just reach out to us. A member of our team will follow up with you. And with that, we are at the end of our hour. So I want to thank you, our audience, for spending time with us today, answering or asking your questions. Hopefully we provided good answers for you and responding to the poll questions. And I also want to thank Pam and Tom for joining with us and putting together these content for the call letter. So thank you all. With that, I'll close for today, and hope everyone has a great rest of your day. Thanks, guys.
Thank you.
Thank you.